Good morning, good afternoon, or good evening, depending on what part of the world you're joining today. Welcome to today's webcast about opportunities in medical tourism for U.S. healthcare consumers. We are going to cover in detail how the U.S. healthcare system works and how to attract U.S. buyers of healthcare. It is my pleasure to introduce you to today's presenter, Mr. Jonathan Edelheit. Mr. Edelheit is CEO of the Medical Tourism Association. Mr. Edelheit is a leader in U.S. and international healthcare and considered one of the world's top experts. He has extensive experience in both U.S. and international health insurance and healthcare and has spent the past 12 years of his career dedicated to U.S. and international healthcare and health insurance issues and has received awards for being an international healthcare leader. Mr. Edelheit was the first person to implement medical tourism in the U.S. in 2004, breaking a lot of the stigmas and biases that people had about American patients traveling overseas. He is one of the most respected experts worldwide in medical tourism and is widely recognized in the U.S. healthcare insurance employee benefits industry amongst employers, insurance companies, and health insurance agents. Mr. Edelheit has helped governments and healthcare providers around the world to develop successful healthcare and health insurance initiatives. We hope that you enjoy the webcast today, and now I would like to turn it over to our presenter, Jonathan Edelheit.
Thank you, Christina. Good day, everyone. Glad to have you on our webcast today. This webcast is really understanding the opportunities. It's understanding the opportunities in medical tourism in the U.S. healthcare marketplace, and also us going over a little bit of what is the U.S. understanding the U.S. healthcare marketplace and what happens within U.S. health insurance. And I think it's going to be really important and a very informative webcast, really breaking down what's going on with healthcare reform here in the U.S. and then the different segments and the makeup of the U.S. insurance marketplace, because there's different, I would say, segments within the industry you have to target. So understanding what those segments are in the U.S. insurance industry and then how you actually can go and target them. This webcast, we are going to make the presentation available after probably about 24 to 48 hours, so you'll get a copy of the video. And also, if any of you have any questions, feel free to ask them as the webcast goes on, and we can we'll provide you, we might answer it as you ask a question or answer it as the webcast goes on or at the end of the webcast. So there's a lot of topics we can cover. It's very difficult in an hour to really cover everything there is to know about the U.S. health insurance system and U.S. healthcare. So, we're going to try to fly through it as fast as possible. This is something I could keep you on a webcast for a week about, but I think it's really important to understand all this because it's very difficult for people to get accurate information on what's really going on with U.S. healthcare, are costs going down, are costs going up, what's going on with U.S. health insurance, what's going on with self-funded plans, are employers or insurers doing medical tourism. And besides the fact that it's very difficult to get information out there, there's also misinformation out there that's shared with people in the industry regarding what's going on with U.S. health insurance, which is totally inaccurate. So it's good to really, get an education on it. So just a brief background, many of you know, are very familiar with the Medical Tourism Association, but we work with all the stakeholders, the buyers of healthcare, employers, insurance companies, hospitals, governments, the wellness side, technology, facilitators. We have over 15 regional offices and 300 members in over 100 countries. And we do a lot of education to three different sectors. We educate buyers of healthcare and medical tourism and help connect them with hospitals overseas. We educate consumers, healthcare consumers from around the world through our destination guides through medicaltourism.com. And then we also educate hospitals and governments and facilitators through our training and certification programs, research and industry analysis, and kind of program development and marketing strategy. And as I mentioned before, we have medicaltourism.com for healthcare consumers, Medical Tourism Magazine for industry, B2B, and then Medical Tourism City, which is a social network for people in the industry to connect. we really have a very fast-growing database, and I really, I'm going to focus a little bit on the U.S. market with our database. But I think it's important to understand because you should really know what channels of communication the MTA have to reach buyers and other major players in the industry, so you can make sure that you're in those channels, connecting with the right people. So if we look at just in the U.S. side, we have about 100,000 followers in about 40 different LinkedIn groups that we run, all focused around buyers, in specific topics, whether it's international insurance companies, Middle East insurance companies and governments, U.S. insurance. We have over about 180,000 specifically in the luxury hotel and travel space. About 30,000 followers on Facebook alone, in a couple different Facebook channels the MTA runs. And then within our access within the U.S. insurance industry, it's almost 500,000, about 200,000 insurance agents and executives, and about 250,000 U.S. employers and TPAs. And anyone who wants to know any of these groups that we run or channels, we'll be happy to discuss it with you. But we've been educating the U.S. insurance marketplace, I would say, since the beginning. As Christina had mentioned, I was the first person back in 2004 and 5 when I ran a national healthcare administrator to implement self-fund medical tourism into both self-funded and fully insured plans. And then since then, being involved in co-founding the Medical Tourism Association, we've been very instrumental in educating the U.S. insurance industry on medical tourism through traveling and speaking at conferences, bringing all the big insurance companies to our events, and a lot of workshops and training programs. And, it's amazing to see the change that's happened. Back when we founded the association in 2007, we held our first conference in 2008, and I worked very closely educating all the top health insurance companies on medical tourism: Cigna, Aetna, United Healthcare, Humana, Blue Cross. And we worked really hard on bringing them all out to our first conference in 2008 in San Francisco. And they were all very skeptical and not interested really in medical tourism, but came out anyway. And right after our events, a lot of them started issuing requests for proposals. So their mindset totally changed from coming to our events and really seeing what was going on in the industry. And to see where we are today versus then, it's really exciting, because what we've seen is insurance companies have adopted medical tourism, and that it has really grown, and employers have adopted it. And we went from no one knowing about medical tourism back in 2007 in the insurance industry to, because of all our work, everyone knows of it. Almost every insurance agent, broker, every employer, every insurer, they're very aware of it, and there's a positive attitude about it. Where back in 2007, you face that skepticism. And I was featured in one of the first articles on medical tourism that was ever done in the U.S., and it was by the International Herald Tribune, which is the New York Times international version. And it was the first article on medical tourism, and it included me and my company, and then also Bummer and Grad Hospital. And then shortly afterwards, we were also in Time magazine. But to see the change of the coverage in the U.S. media from where it was then to where it is now, it would get mentioned in the beginning maybe 5 or 10 times per year when we first started, and now it's like multiple articles every day in the U.S., multiple articles around the world. So there's thousands of articles written every year on medical tourism. So the awareness, the coverage, it's really grown substantially. So to go over the overview of the medical tourism industry. So most developed countries have national health insurance programs, and it's referred to as universal access. So everybody is usually covered by the government. The one thing that I think that we see is that that is not how it works here in the U.S. So here in the U.S., it's not covered as universal health care. So there's no central governing agency, although technically you could say the HHS and the government are now, kind of governing it because of healthcare reform. I'll go into that in a little while. But it's not like the UK or Canadian system where it's all covered by the public sector. It's still primarily private driven. and there's high costs, unequal access to care, and average outcomes for many people, and the outcomes depend on what access that you have and where you're actually going for care. So people who might have access to go to very high quality centers of excellence are going to get better care than those who don't have access to that, and that can depend on whether you're paying cash or what health insurance plan that you have. So under healthcare reform, many of the top plans not many of the top plans. Many of the plans that are being covered under healthcare reform that are being offered in what are called the marketplaces or exchanges, they don't cover the top centers of excellence. They're not playing. And then with Medicaid and Medicare, many of the top centers of excellence also don't participate in that. So you really need to have special insurance to have access to the top centers of excellence. If we look at real quick, per capita total spending, this is back in 2009, you'll see the U.S. Has the highest, almost double of what most countries have, so we spend almost double the care. I'm going to fly through some of these slides because I really want to get into the substance about about healthcare reform, about self-funding, about fully insured plans, and so forth. So we have Medicaid and we have Medicare. So Medicaid is for people who can't afford insurance, and they're referred to more as the poor people in the United States, the ones that they make under a certain amount of income, and because they make less a certain amount of income and less than other people, then they can be covered by state or federal insurance, and they have access to care. So there's a common misperception that people will say, well, the uninsured are the ones traveling for care, and they're poor people, but the poor people are covered by Medicaid. And I think the average uninsured makes about $50,000 a year, the last statistic that was done. And then you have Medicare, which is for people pretty much 65 or older or with certain disabilities. So those are the older American citizens, and they're covered by the federal government under the Medicare program. So what are the key buyers of healthcare in the U.S.? So there are really three segments. There is self-funded employers, there is fully insured employers, and then obviously there's the uninsured, and then Medicare and Medicaid. So let me go into the self-funded employers first. So large employers are technically, they're considered 50 or more. They have 50 or more employees here in the U.S. That's what most people consider large employers. But for purposes of statistics and surveys that we're going to be showing, we're going to focus on some stats. So with one survey that was just recently done, larger employers with 200 or more employees are more likely to self-fund, and 83% offer some kind of self-funded plan. So I think this is really important for people to focus on because they don't realize the majority of employers in the U.S. who are large all have self-funded medical plans. And 61% of covered U.S. workers are in self-funded plans as of 2013. So, when I first started educating everyone globally on medical tourism, when the MTA was founded, I did a lot of education on self-funding and explaining this should be a big target of what facilitators, hospitals, and governments should focus on. We've seen a change in a lot of hospitals and governments and facilitators, focusing on going after self-funded plans, but I'm going to try to go into a little while, really explaining self-funding, what is it, and then why you should go after it, and then how you should target it. But I think these statistics are very important because a lot of people don't realize that how big self-funded plans are and how that should be the focus versus necessarily going after fully insured plans. So self-funded plans are companies that basically create their own insurance plan for their employees rather than using an insurance carrier. So rather than using the Blue Cross Blue Shield and Aetna, Cigna, and paying them a premium, the employer decides, I'm going to take the risk on with myself, and I'm going to bring some vendors and service providers on who will do the same functions that an insurance company would to see if I can save money. And the reason why they would do that, as an example, is you could, as an employer, be paying $2 million a year to Blue Cross Blue Shield for your fully insured health plan. And you have no risk because you pay them $2 million a year, and anything above that Blue Cross Blue Shield pays. Meaning if the medical claims are really bad and they're over $2 million, Blue Cross Blue Shield pays it, and you don't as an employer. But if you're self-funding, you're taking on the risk of saying, okay, if I'm self-funding and I have more than $2 million in claims, then I as a company have to pay that. So you potentially, when you go self-funded, you may pay more than you were fully insured. But where the risk is that you're taking is you're basically going ahead and saying, well, what if my medical claims are really $1.5 million for the year? I'm paying Blue Cross Blue Shield $2 million, and if I actually went self-funded, I would save $500,000. So that is the reason why employers go self-funding, is the potential to save money. But there's also the adverse risk of paying more than they would with fully insured. So we usually, we talk about it as risk because the employer is willing to take the risk. And these are just some logos of some big companies that are self-funded. And if anyone wants, I can send them examples of how self-funding works. And in our next webcast, we'll pop in a couple examples that we've used in the past that really show you some examples of how self-funding works compared to fully insured and the stop loss. So when you're self-funding, you also have stop loss insurance. So you're not fully self-funding. And what I mean by that is it all depends upon the size of your company. So there's a stop loss deductible, which is the employer basically pays a certain amount up to a certain cap per each individual or employee on the plan, and once that is hit, then the stop loss carrier or the reinsurance carrier comes onto the plan. So if that is $50,000 per employee, that means, for example, if we're looking at Walmart as an example, Walmart pays $50,000 in the first medical claims for each employee, but once it hits $50,000, then the reinsurer comes in and pays the balance. So what this means is the self-funded employer has a real incentive to keep the stop-loss claims down because that's money out of their own pocket. When they were with Blue Cross Blue Shield fully insured, they didn't have to worry about it because they pay premiums. That $2 million per year example, which is, when I say $2 million, it's never a set amount. It's based upon the employees and the coverage that they have. So the rates will differ per employer, but what it means is that with Blue Cross Blue Shield, they would pay their $2 million, and they didn't have to worry about what their claims were and if their employees were sick, because Blue Cross Blue Shield would just pay them. With self-funding, they do care because if someone needs a hip replacement or a knee replacement or a heart procedure, that knee replacement could be $50,000 to $80,000. So they know they're paying that first $50,000. So if they could get that person to go, for example, to Costa Rica, to Thailand, even traveling within the U.S. for domestic medical tourism, that savings goes directly into the employer's pocket. So that's extremely important. And then for the stop-loss carrier, the reinsurer, they really like medical tourism because if the employer can control their costs and keep it below the stop-loss deductible, then that means the reinsurer never gets hit with a medical claim. So the savings is very important. So moving on to a TPA. So a third-party administrator is a person, so this is what typically the employers hire, is a TPA, and this is who I worked for in my past, and the TPA administers health plans. So the employer, when they're self-funding, they outsource a lot of the roles the insurance company would play to the TPA, and the TPA pays the medical claims. They act like an insurance company. They handle customer service. They issue ID cards. They put together a medical network. They handle everything for the employer. So the TPA is a huge area that I think that the medical tourism marketplace should focus on and need to get buy-in into approach to implement medical tourism because they're the ones administering the plan on behalf of the self-funded employer. Then outside of self-funding, you've got insurance companies. So these are companies, like Aetna, Bupa, Cigna, United Healthcare, Blue Cross Blue Shield, and they're your normal fully insured carriers where you pay premiums that are set each month, and then they pay the medical claims. So, but the fully insured carriers also do administer self-funded plans. So they do some self-funding, although it's a small portion of their business, and a majority of their business is fully insured business. Then what you also have is the brokers and agents and consultants. And these are very important because they are the ones that educate the employers on what to do with their health plan. So the brokers, agents, and consultants are the ones that bring in the solutions for the employer. They're the ones that will tell them, hey, you should switch insurance companies from Blue Cross to Aetna. Hey, you should look from going fully insured to self-funding. They're the ones that say, hey, you should implement a new benefit plan. It could be disability. It could be medical tourism. So they're the advisor to the employers on their health insurance and employee benefits. And there's different segments. You have brokers and agents, which typically receive a commission on the health plans. And the commission is kind of being attacked in the fully insured realm, not as much on the self-funded plans, because healthcare reform, the healthcare reform law is really trying to reduce the roles of brokers and agents and kind of cut them out and eliminate their commission, which is very unfortunate because they do a lot of education, the brokers and agents, to the employees, and they're the ones during annual open enrollment that are actively out educating and communicating with employees on new benefits and how to enroll in them and why they're positive, and then they also do customer service during the year. So they're an integral part of the process. So the brokers, agents, and consultants are very important because you really need to get their buy-in in the area of medical tourism because they're the ones that are going to go advise the employers on implementing this new benefit. And also, you have the TPA that are an integral part because they're paying the medical claims. And then you have also the stop-loss insurer. So every single one of these, you need to really get them to buy into this type of program. So I'm going to move. Oh, the one thing that I did forget to mention is consultants. So then you have the consultants, and consultants are different than agents and brokers, but they also represent the employer and their insurance. And they actually don't get commission. They're usually paid a fixed fee for the year or an agreed upon fee. These are the Aons, the Mercers, the Marsh, and they kind of do very similar things to the agents, but don't necessarily make the recommendation as to which carrier or benefit they should go to. So they'll give the client a couple different options. But the key part here is they don't get commission. And I'll be going into a little later in a couple slides is how you kind of approach each market, because it's very important how you approach the market. So, I think one challenge that we're seeing in medical tourism with the U.S. market is a lack of understanding how do you actually communicate and talk to the different players, whether it's the insurance company, the employer, the TPA, the broker, the agent, the consultant. How do you communicate with them? How do you talk with them in their language? And how do you offer something in a way that they can implement? So there's a lot of breakdown that's happening all along this process, and a lot of errors that can be made. So looking at employer and sponsored plans, one important thing is under the Obamacare, healthcare reform, the Affordable Care Act, self-funded plans are taking off under ACA. So if anyone tells you that self-funded plans are not doing well or are not going to take off under healthcare reform, they're totally inaccurate. because healthcare reform, fully insured plans have certain mandates and taxes that self-funded plans don't. So more companies are shifting to self-funding, and they have more advantages to go self-funding. And we're also seeing a trend of more small employers going self-funding. So in the past, you really would never hear of small employers of 10, 20, 30, 50 employees going self-funding, but now there's a lot of new products and services that are being offered for these small groups to go self-funding. So there's a big growth factor in self-funding, and why is that positive? That's positive because when the one thing that I didn't cover is when an employer is self-funded, they can make any decision that they want almost instantly with their benefit plan. So an employer tomorrow could say, I want to implement medical tourism, and snap of their fingers, they put in one clause into what's called their summary plan description in their plan document, and medical tourism is now allowed. And the self-funded employer, the director of HR may be making a decision with the CFO or CEO. It can be made very fast. There's not a lot of bureaucracy. There's not a lot of delay. Where with a fully insured carrier, there's a lot of bureaucracy, a lot of compliance that has to happen, and it may take a very long time for it to be implemented. So this is the advantage of why it's very exciting, healthcare reform, pushing more employers to self-funding and more self-funding employers implementing medical tourism. And I'm going to go into some case studies in a little while of self-funded employers doing medical tourism. As I told you, I was the first one to do this starting back in 2004. If anyone tells you healthcare reform somehow is going to stop people traveling from the U.S. for medical tourism, and it's not positive for medical tourism, and self-funding is not positive for medical tourism, it's absolutely not true. That is totally, I'll go to the extreme and say it's a lie. And whoever you're talking to really doesn't understand the U.S. health insurance marketplace or anything that's going on with it. So medical tourism is growing under self-funded plans, and I'll go into that in a little while ago in a couple slides. So this is some example that I was mentioning. When you're fully insured, the column on the left, you've got your medical claims, your administrative expenses, which is more expensive under fully insured. You have to have reserves, which are required by the state departments of insurance, meaning putting away money for potential claims. You've got to pay the profit of the insurance company. So that's a very key point, is when you're self-funded, it's the employer doing it. They're saving whatever isn't spent. When you're fully insured with Blue Cross, Aetna, Humana, you've got to pay the insurance company's profits. And then you also have to pay premium taxes, state premium taxes, which you don't when you're self-funded. So let's go into the Affordable Care Act and healthcare reform. So I've been a leading educator here in the U.S. on healthcare reform since back in 2010. And besides being the CEO of the Medical Tourism Association, I'm also the president of the Healthcare Reform Center and Policy Institute. And we're one of the leading educators on healthcare reform in the U.S., doing a lot of training and education around the country. And I've been bringing that education to the medical tourism side to really make people aware of what's going on with healthcare reform here in the U.S. Because in medical tourism, there's a lot of misunderstandings about what's going on. And some people think that this means it's like universal healthcare like the UK or Canada. And now people won't need to travel and everything will be covered. Even in the U.S., if you ask the average American, they don't know what the Affordable Care Act, what healthcare reform really means. They think it means free healthcare, free surgeries, and it really doesn't. And then there's a lot of information that will circulate out in the medical tourism industry saying, healthcare reform is going to lower costs, and people are going to be covered under the state exchanges, and people are going to stop traveling, and it's totally not true. In fact, there's been a couple people in the medical tourism industry who, maybe they're sending patients out from a different region, so they've been trying to push a lot of misinformation out there to hospitals and governments to try to get them to not understand the U.S. healthcare industry and to make them think the industry is not growing, so that they focus on the market where they're pushing a lot of advertising and marketing from. So the healthcare reform law is over 1,000 pages. It's over 30,000 pages of rules and regulations. With the rules and regulations alone, it's almost 11 million words. And there's between, I think, 159 to 180 government agencies, committees, bureaus, commissions, all dealing with rules and regulations. So the healthcare reform law is extremely complicated. It's had a very difficult rollout. And one thing is costs have gone up. Costs have not gone down. And we'll be going into this in a couple slides. So I'm going to skip through a couple of these slides because we really won't have time to go over everything, but you can really view this afterwards because we'll be making the slides available. This is just a chart of people putting off care because of cost. This is a chart showing how much health insurance has grown since 2000. It's grown 147% for employees' contribution to premiums. This is showing another, similar thing of how it's increased since 1999, the cost of what the employer pays and what the employee pays. So it's gone up very significantly. This is a chart that's really showing the high out-of-pocket costs because of chronic conditions. So healthcare reform has been very positive. It waives pre-existing condition clauses. It eliminates annual and lifetime maximums. So if you had a healthcare condition before, you might be pre-X'd and say you can't have coverage for a year or a couple of years, or we're going to limit your annual or lifetime limits to $500,000. So that's all been eliminated. So now, there's no lifetime or annual limits, so someone could run up $5 million, $10 million in medical claims. And if you waive pre-existing conditions and you make insurance guarantee issue with no annual or lifetime limits, it's very common sense that costs are going up. It's just a simple mathematics and economics. It's like saying every car that will be sold now by Toyota will only be the top-of-the-line car with the top-of-the-line interior. It's only going to have leather seats, navigation system, heated seats, rear view camera, for backing up, self-parking, automation. If you're going to have a top of the line with no limits, costs are going to go up. Before healthcare reform was passed, there were some high-end estimates that individual health insurance could be almost $14,000 a year and family insurance about $40,000 by 2020. So health insurance and healthcare is already unsustainable. And everyone's tried everything, such as high deductible plans, consumer-driven plans, and things like that. So one of the challenges by saying there's guarantee issue with no pre-existing conditions is that this means there's no real incentive for people to be healthy. And to give you an example of that, if you have Jane, and Jane works out 5 times a week, eats nothing but vegetables and healthy food, and doesn't drink alcohol or smoke. And she pays her insurance every month and stays on insurance. And then you have Joe, and he smokes cigarettes every day. He drinks a liter of vodka every day, and he never works out, and all he eats is fast food. Jane and Joe pay the same insurance premium, regardless of the fact that Jane is living a healthy lifestyle and Joe isn't. And then another aspect of that is Joe doesn't need to buy insurance. He can wait until he's sick 5 years from now, and when he's sick 5 years from now, he can buy insurance at the same rate Jane is paying. And what that means is Jane's insurance rates have to go up to subsidize the people who are living unhealthy lifestyles and who are sick who have chosen not to buy insurance. And one would say, okay, well, they implemented an individual mandate saying you had to buy insurance, and if you don't buy insurance as an individual, you'll get fined. But that insurance fine is very small. It's $95. For the first year, that's broken out monthly. So you're basically talking about almost $8 a month someone has to pay in a fine for not having insurance. And when their insurance might be $500 a month as an individual or $1,000 a month. So the fine is so small that it is not really a mandate or a penalty, and it doesn't incentivize people to buy insurance. It's almost a disincentive. So you can pay your almost $8 a month, not buy insurance, wait till you're sick, and then buy insurance and get covered at the same cost as a healthy person. So that causes a lot of problems, and it also causes in the insurance industry what we call our adverse selection. And then there's been a lot of employers that have started to drop benefits for dependents. Delta Airlines said in 2014 they're going to have to pay $100 million more for their health insurance because of it. UPS and the University of Virginia have both dropped dependent coverage. And I'm going to skip through some of these slides. Another thing is healthcare reform was supposed to charge younger Americans, senior citizens, 5 to 6 times the rate as younger people because they use more health insurance, they use more medication, more hospitalization, but healthcare reform artificially reduced it and said senior citizens can really only pay 3 times the cost of a younger person. So what does that mean? If it's really supposed to be 5 to 6 times the amount, but they're only paying 3 times, it means that younger people's insurance have to almost double so that older people's insurance come down to a lower level. Now, it's really difficult to get young Americans to buy insurance anyway because they feel they're invincible or they're young. And so now you're basically saying we're going to increase young, healthy people's rates by making insurance guarantee issue with no pre-ex. So they've got to subsidize sick people and unhealthy people, and they've got to subsidize the older people. So, younger people's rates have to significantly increase, and then the sicker people and older rates decrease. And what's happened is it was common sense. Everybody knew this back in 2010 when the law was passed, and no one talked about it. It meant that healthy people and young people are going to not enroll in health insurance or drop out. And what we've already seen, and it's coming out as if it's new news in the last couple months when we knew it for several years, is young people aren't enrolling in health insurance and the healthy people aren't, and they're getting adverse selection because it's older and sicker people that are enrolling, and that costs are going up. So one of the things that's important is there was an employer mandate that said employers that were large employers had to go ahead and offer health insurance to their employees, or they'll get hit with a $2,000 fine or a $3,000 fine per employee. So that's very significant. And that means if you had 100 employees and you didn't offer insurance, you could get hit with a $200,000 fine or a $300,000 fine. So this was a way to get employers to mandate and make sure they offer health insurance to their employees. And one thing that happened was this was supposed to go into effect January 1st of 2014 this year, and they had a delay for it. And now employers with 50 to 99 workers will be given a later date instead of the original 2014 date. So companies, and also they had to offer coverage at a certain percentage level of what was affordable to that employee based upon what that employee's salary was. And they changed that to companies with 100 workers or more are required to offer coverage to 70% of their employees instead of the original 95%. So they've lowered what percentage of employees have to be offered coverage and enrolled. And then they actually have delayed the date of when that enrolls to 2015, and then it's 2016 for smaller employers. Now, what we've already seen too is letters from the insurance companies, like Humana already going out to their individuals talking about rate increases, and they're saying your premiums are going up specifically because of the Affordable Care Act. So we've seen that from Aetna, we've seen that from Humana. This is an example, and I'd like to give case studies because I think it's really important. So rather than saying, hey, this is kind of what's going on, seeing the real effects. So Andy and Amy from Louisville, Kentucky, their insurance tripled in 2014. It went from $333 a month to $965. And they basically got a letter from Humana saying it went up. And there was many factors of their premiums going up per month, including the Affordable Care Act compliance, healthcare reform, and healthcare reform's addition of new essential benefits. So you imagine an American's individual insurance tripling from $333 a month to $965. That's unaffordable for some Americans, and that's going to require people to drop out of coverage. Forbes, September 25th of 2013, said healthcare reform will increase the average individual market insurance premiums by 99% for men and 62% for women. That's very, very large. So, as I said, the positive of healthcare reform is that if you are sick, if you have a condition, you now can get guaranteed coverage and won't get turned down. And there's no limits on annual or lifetime maximums. But with all the benefits that were put into healthcare reform, costs have gone up. And then they created these state exchanges or federal exchanges and what they are now calling marketplaces, where they said individuals could come and buy their insurance and it would cost lower. But the reality is the costs have gone up in most of the exchanges. There are some exchanges where costs went down, but in the majority of them, costs have gone up. So it's more expensive for the individuals. Now, I want to go into a case study. So, we were talking about fully insured care, and, we have carriers like Aetna and Cigna that have implemented medical tourism in their fully insured plans. And then what we also have is we have self-funded plans. And with self-funded plans, there has not been many employers that would go on record and say, hey, we're doing medical tourism. Even the fully insured companies, they're not out there broadcasting in the media and the news, we're doing medical tourism. They're doing it very quietly, kind of behind the scenes, because one, with what's going on with healthcare reform, they don't want to cause any issues with the Obama administration on sending patients overseas. Also, a competitive advantage. They don't want their competition to know what they're doing. And third, no one necessarily wants to be the first one out there and to deal with media attention, whether it's positive or negative for what you're doing. Now, we recently, worked on, I'm sure many of you saw it, but we worked with Diane Sawyer in Nightline, one of the top reporters in the country and top TV shows, in putting together a whole story on the first self-funded employer in the U.S. to go on record on the news and say we're doing medical tourism. We've been doing it for like 5 years, and it's successful and it's working. So we put the whole story together. HSM, they're a Hickory Springs manufacturing. They're a member of the MTA. The hospital they went to was a member. And we put the whole story together from start to finish with Nightline. We work with the media around the world all year long. This is kind of what we do. And it was the employer they saved $10 million over 5 years with a self-funded plan. This story is so positive because what it is going to be the case study and the model story that other self-funded employers will use to implement medical tourism. They saved quite significantly, and they sent over 250 employees overseas for medical procedures. And they provided incentives to their employees, and they sent their employees to India, and they've also sent them to Costa Rica. And I could send you a link to that story if anyone would like to see the link. It's on the MTA's website and also our Medical Tourism Conference website. But this is an example. I mean, imagine $10 million in savings over 5 years. So they sent 250 employees with no one knowing about it and never being on the media, never being talked about even in the industry. So this stuff is happening in medical tourism, but people are doing it very quietly. But what the HSM story is going to do is it's going to open the doors for other self-funded employers and other insurance companies who never had a case story to look at to say, look, this employer's done it, and it's not something that they just tested out or it's been in a very small number. It's a very large number of employees over a large number of years with a large number of savings. So it shows it works. It shows the quality is there. It shows the savings is there. It shows the employer can deal with all the issues such as complications, liability, and it shows that the employees love the benefit and utilize the benefit. And so this is going to be the case study that moves everything forward in the U.S. and gets a lot more employers very encouraged to say, hey, I can do this now. Because you can imagine in any industry when you don't have an example to look at, it's going to slow down the adoption of the industry. So one of the things I'd like to address is how does healthcare reform affect inbound medical tourism to the U.S.? We get that question asked because we also work with a lot of U.S. hospitals. It doesn't affect inbound medical tourism at all. Patients are always coming to the U.S. for high-quality care, whether covered by a private insurer, foreign government, or a cash paying. And the inbound medical tourism marketplace is going to continue to grow because people from outside the U.S. really love the high quality the U.S. has to offer at some of the top centers of excellence. How does healthcare reform affect domestic medical tourism? So domestic medical tourism is really growing fast, and some examples of that: Lowe's partnering with the Cleveland Clinic, Pepsi partnering with Johns Hopkins, Boeing has implemented it, Walmart has implemented it, a lot of U.S. employers, and that's same concept as international medical tourism, but domestic, saying, hey, travel to a hospital within the U.S. And we'll waive deductible co-insurance, and we'll cover your travel expenses for you and a loved one. And that is really growing very fast. And I think that's very positive, too, because as that grows, that's showing U.S. employers and insurance companies' willingness to incentivize employees to travel for care. So, moving on to, I would say it's, not all about being competitive in pricing. So, I apologize if this chart is a little blurry. Hopefully that, you can see it. But it's important to understand, how do you approach the U.S. insurance marketplace? How do you approach HR and insurance executives in medical tourism? And this is where I think there's a tremendous amount of breakdown with the medical tourism industry, because it's not just about pricing. It's not just about brochures, pretty brochures and pretty websites and sending emails. When you're dealing with cash-paying patients, pricing is extremely important. When you're dealing with the insurance marketplace, you have to take a step back and realize pricing isn't everything. And this is where some people go wrong, is they'll focus all about pricing and say, we have the best pricing. We're the most competitive. Send it to our hospital because we're the cheapest. That is not going to necessarily really strike a positive chord with the employer, the insurance agent, or the insurance company. Yes, they want savings, but they primarily want high quality. So if you focus your approach and your conversation just about pricing, I think you're going to totally lose their interest and their focus, and they're going to think this person doesn't understand what we do, and they don't necessarily care about quality because they're only concerned with pricing. So to really explain this, if I'm a U.S. employer and I want to save money by implementing international medical tourism in my plan, and I have a knee replacement, and that knee replacement costs $50,000. And knee replacements can literally cost anywhere from like $20,000 to $30,000 in the U.S. to almost $80,000 to $100,000. And just so everyone knows, if you're not familiar with the U.S. insurance marketplace, no one really knows what the cost of procedures are anywhere in the U.S. or anywhere in a city. I worked for a national TPA. And I did all the contracting with our medical networks. I did all the marketing and sales. I worked with all our insurance companies, too, for our fully insured plans. Is the rates of everything vary based upon what city you're in, which hospital you're going to, which doctor you're going to, the implant, everything. So you could go to the same hospital and get a totally different rate for a knee replacement. Because it's different doctors. You could go to a hospital across the street in Miami from another hospital, and the rate is 50% less. So no one can really tell you what the costs are, but they know. I know for a fact $20,000 to $30,000 for outpatient at the lowest for people who have certain indicators, and they go to outpatient facilities, or as high as up to $100,000. So if I'm a self-funded employer, one of the positives of international medical tourism is obviously the fixed pricing, knowing I'm paying a fixed cost and I can budget and I know what my cost is. The second part I want to know I'm going to get very high quality and there's going to be positive outcomes and my employees will have a good experience and be back to work fast. And the third, I'm going to save money. So if my cost is $50,000 for a knee replacement, and let's say in India, let's say it's $7,000, and in Costa Rica it's $11,000. So that's the difference between me saving $43,000 and let's say $39,000. To the insurance company or employer, that's not a big difference. Their main focus is going to be that their employee or their insured get high quality care, and that their insured actually is comfortable traveling to that destination. So they will take less savings in order to make sure there's quality, and they will take less savings to make sure that that patient wants to travel to that destination. So to take a step back and to give you an example is, I think that a lot of U.S. insurance companies and employers, they don't just want one destination. They want multiple destinations, because you could have an employer who they have employees who they could be of Hispanic descent or Mexican descent. Now, if they're of Mexican descent, where do they want to go? They probably want to go back to Mexico for care, for medical tourism. And if they're Mexican, maybe they're not comfortable going to India. And then you could have someone who's an Indian American or of Indian descent working for a U.S. employer, and they're comfortable going to India or Asia for care. So the employer or the insurance company isn't just going to say, well, I'm just going to select India and just send all my patients to India, or I'm just going to select Thailand or just Costa Rica, because then what you're going to have happen is you're going to have employees or insured who just aren't willing to travel to that destination because they're not comfortable with the culture or the quality or just traveling to that specific country. So you need to understand, one, it's where they're comfortable traveling to, but two, the quality is so important. If an employer or an insurance company could say, I can send my people to a specific hospital in India, and this is the top heart surgeon in the world that's done 5,000 of these heart procedures, and the outcomes are there's a 10% better survival rate than sending them to Germany, that is what's going to get that employer to send that patient to India. It's not going to be, hey, we're $30,000 cheaper for this procedure in India than Germany. So it's important to understand how to have that conversation and the key factors that's important to them. One of the key things that I'll say is, you got to focus on things, like I was talking about is your first step isn't let's focus on marketing and let's focus on search engine optimization. That shouldn't be your first fit. I'll talk to a lot of people and they'll say, oh, we just invested a lot in a marketing brochure on our website on search engine optimization. Now, when you search, medical tourism in India or Thailand, we come up number one. Well, one of the problems with that is everyone has a nice website. Everyone has a nice brochure. Everyone has invested in SEO. That's not necessarily going to get you patients or help you convert your patients. And for employers and insurance companies, you should be focusing on the high quality of healthcare, the experience of your doctor, the positive outcomes, how you can communicate your lowering risks and liabilities, and providing an experience where the employees and the insured clients feel comfortable. And more importantly, how to communicate and talk in the language of those buyers and how you're actually going to meet those buyers. Meaning, it's not going to be through email. It's not going to be through LinkedIn. I get people in the insurance industry, because I work with all the big insurance companies. I work with all the big consulting firms, all the agencies, the CPAs, on a lot of different projects in healthcare, in medical tourism, and benefits. They'll still send me messages where someone is just sending them a message that's like, hey, we've got, in our country, at our hospital, we're the top destination in our country. We have really high quality healthcare. And this is what we do. Here's our brochure and pricing. Please send us patients. That will never work. That has never worked, and it will never work, and you're going to have the opposite effect. And then we'll have some that will mention and will pay you commission. And that's not going to work at all. That's a total waste in your marketing initiative. You need to know, especially with the U.S. market, am I talking to an agent or broker or consultant? Am I talking to an insurance company, or am I talking to an employer? And you need to pivot and change your conversation and your approach based on who you're talking to. So if you're dealing with an employee benefits consultant, you're not going to mention commission because they're not allowed to get paid commission. So you're going to turn them off. If you're talking to an agent or broker, they get commission. They want to hear about commission. If you're talking to an insurance company, you're not going to mention commission because the insurance company isn't going to make that commission. And can't necessarily take that commission. So you can basically, stop the conversation immediately by approaching the people in the wrong way. or by approaching it and how you start your message with them. Just sending an email, just hoping, you're going to send out a ton of emails and someone magically is going to pick up the phone and call you and say, I got your email. I hear you're the top hospital in Costa Rica or in Germany or in Singapore. I want to send you patients. It just simply doesn't work that way. I've never seen one email come across in that way that addresses any of the issues that a buyer would want to send patients to that country. Another underserved market that isn't really targeted, that I've advocated for years here in the U.S., is the multicultural market or the ethnic market. For those of you who don't know, the majority of babies being born in the U.S. now are not like white Caucasians. They're multicultural and ethnic. So, starting, I think it's this year, white Caucasian babies are in the minority now. So there's a lot of, Hispanic Americans, Asian Americans, European Americans, and it's important to target these sectors, to go after employers, to go after insurance companies, to go after cities and destinations that have these ethnic individuals living in them, because for them, it's very easy for them to make a decision to travel overseas because there's no cultural barrier, there's no language barrier, and they're comfortable traveling to those countries, and they may have extended family who will help them. And when you look at some of the statistics, when surveys have been done, I think it was like 39% of Caucasian Americans would be willing to travel overseas, if the quality of care was equal to or greater, and the savings was equal to or greater than in the U.S. But when they looked at the multicultural ethnic side, it was something like 55% of Hispanic Americans and Asian Americans would be willing to travel overseas. So this is a very underserved market that should really be focused on. And this is just some stats on the ethnic workforce. So I think it's very important in order to develop a successful strategy, knowing your target audience. Am I approaching self-funded employers? Am I approaching the TPAs? Am I approaching the insurance companies or the agents, brokers, and consultants? What are my things that I'm focusing on? With insurance companies, they're going to focus on high quality and hospitals that have high volume of patients, so they can look at the quality outcomes in very large numbers and assess the quality, and providing quality tools to educate their consumers. By the way, if you're approaching self-funded employers, do not talk about commissions. Self-funded employers get savings on their plan. They're not interested in commissions, and you'll turn them off right away. I've heard of deals being killed. There was a hospital in Turkey that was dealing with a international insurance company, and they were in a meeting with them, in a networking meeting at our conference, and they were trying to convince them to send them patients. And it was very focused on, we have great health care, we have great doctors, not a lot of substance in going into their doctors, their quality, their outcomes, their experience, and said, we'll give you 10% commission if you send us patients. And the international insurance company said, no, it's okay. I don't need commissions. We're not interested in commissions. And what happened is the Turkish hospital, they actually thought that the international insurance company was playing hardball negotiations with them. So they came back and they said, we'll give you 15% commission. And the international person representing the international insurance said, no, I don't need 15% commission. We're more interested in the quality and the savings. And the Turkish hospital continued and said, okay, I'll give you 20% commission, and that's the most that I can do. And that might work for the Turkish hospital in other countries dealing with buyers who might be referral sources, or even with people who might represent governments and things like that. But it doesn't work with the international insurance companies, and the international insurer just walked away from that that opportunity. And they kind of told me, they were kind of joking about that story, and they were telling me it later that the hospital just didn't get. The insurance company can't make money. It's illegal for them to do it, and it's unethical for that individual to try to do it themselves. And they're concerned more with the quality and the outcomes and the experience of their insured. So that Turkish hospital totally lost the opportunity because they didn't understand who they're talking about, And this is the most important part of strategy in medical tourism. So this isn't, what I'm talking about now isn't just an issue for the U.S. market, it's an issue for the global market, is understanding exactly who you're talking to, what their role is in medical tourism, what their interest is, what they want to hear, and what they don't want to hear, and focusing on that conversation. It's important to develop a multi-channel approach to medical tourism. So that's another area. So if we go back to looking at, I'm going to scale back a couple slides to try to find that breakout. Well, where was that? Right, this one. Self-funded employers, TPAs, insurance company, agent brokers, or consultants. If we're dealing in the global marketplace, you could throw in referrers, you could throw in medical tourism facilitators. You want to approach every single marketplace. You don't want to just say, I just want to go after agents. I just want to go after CPAs. I just want to go after self-funded employers. You want to go after all of them because you never know which one is going to bring you in the door. So I did self-funding, and we did a lot of innovative health insurance plans, a lot of innovative types of products and services. I launched one of the first low-cost health insurance plans in the early 2000s, which took off on a national basis and got us in the media news all the time, my TPA. And what we would do is we would go after the agents and brokers and consultants, and we'd create relationships with them, and they would then go ahead and bring our products and services and advise their clients, who were the employers, to implement them. And some of them worked with TPAs and advised the TPAs. We then would also go directly to the self-funded employers and talk to them. And in some of those cases, the self-funded employer liked what we had to say, and they also referred what we were doing to the agents, brokers, and consultants. So then the agents, brokers, and consultants would come in, and then they would learn about our product, and they would help implement it with the employer, but they would also bring it in to their clients. So for those of you who don't know, the agent, broker, or consultant, there are small ones that they might have 5 clients that are employers. And then you have some that have thousands of employer clients. So if you get into an agent or a broker or consultant and they really believe in your product, they can take that medical tourism product or whatever it is, corporate wellness, anything, and they can bring it out to a lot of their client base. And then we would also go out directly to TPAs, and TPAs we would convince to do certain things, because then what the TPA could do is they were the administrator for the self-funded employers, and they could roll out the program to the self-funded employers and also advise the agent and the broker. And you never know which of the channels is going to be the most successful, because you could go into a case where the agent is really passionate and they convince the self-funded employer and the TPA to do it. You could go into a case where the agent is not passionate and you have to go to the employer to get them to be passionate, and then they convince the TPA and the agent to do it. But you need all of these parties to work together, because even if the agent loves it, if the self-funded employer doesn't get behind it, they might not educate their employees about it. And if the TPA doesn't get behind it, there's things that the TPA has to do within the medical tourism program to help catch medical cases before they go to a hospital or get referred for surgery, and identify which ones could qualify for medical tourism. So you really need to get everyone involved. One of the biggest problems that we've seen in the industry is that there's no education to the actual employees. And this is what I did, and was a major focus of what I did. What I was doing this back in 2004 and 5. And there's been a lot of people trying to get into medical tourism, whether it's from the international side or even people from the U.S. insurance market, and they're not focusing on the employee engagement. And I developed a lot of innovative things on the employee engagement side to get medical tourism utilization. And the key word is utilization in the insurance industry. So remember that word, repeat it when you're dealing with the insurance industry. And that's important, because what's the point of implementing medical tourism if you can't get employees to utilize it? And utilization is not something new. This is something employers and agents and TPAs deal with every single day. So if you're implementing corporate wellness, how do you get employees to utilize it? If you've got a consumer-driven plan, how do you get employees to utilize it? So what's really important on this is what are you giving to the employees and putting in their hands to get them to do it? A perfect example of this is, one of the early adopters, I would say a year or two after I was doing medical tourism with plans, was Blue Cross Blue Shield of South Carolina. And for the first year or two, and I have no idea why they did this, they offered no incentive for the employees or the insured to travel overseas. So the incentive that self-funded employers are doing is waiving deductible and co-insurance and covering travel expenses for that person and their loved one. And I apologize for not having an example in here of that, because having an example in here would show you how important that is. And if you haven't watched the HSM employer story where they saved $10 million over 5 years, watch it so you can hear how the employee was incentivized and how they feel about it because they love it. So an employee might have a $2,000 deductible for surgery, and they might have another couple $1,000 in out-of-pocket expenses. So if you waive deductible and insurance, that could be $5,000 in savings, which is huge for an employee, and you're paying their travel expenses for them and their loved one. So when Companion Blue Cross Blue Shield of South Carolina, for the first year or two, they offered no incentive. So what that actually meant is it cost more for the person to travel overseas to like Costa Rica or India or Singapore than it would for them to get it locally in the U.S. It might cost thousands more. So it was absurd, and there would be no reason anyone travel. And I remember there was a foreign government who partnered with a U.S. facilitator who was trying to bring them into self-funded employers. And it took me a year talking to that facilitator to finally convince them to offer incentives. So for the first year, it was, why should we offer incentives to the individuals who are with these self-funded employers to travel? And I know to me it's very common sense. If you don't incentivize anyone, why would they travel? And why would they have to pay more to go overseas? And their attitude was, well, the self-funded employer should just force them to go because the cost is lower and the quality is still good. And it doesn't work that way. Self-funded employers cannot legally force employees to go overseas, and they should never do that. That'll expose them to tremendous liability. You need to let the employee make the choice, but you need to convince them to go overseas. And I always put myself in the shoes of that employee and say, what would convince me in the quality and everything, because why would I go overseas? If I'm going to travel, and I'm involved in medical tourism, if you told me tomorrow I've got to go overseas for a heart procedure, I'm gonna want to start asking the question is, what's the hospital, what's their quality, what's their outcomes, what's their complication rates, who's the doctor, where did they go to school, how many procedures have they performed, what are their outcomes, and that's what's going to convince me to go overseas. And let me talk to some patients who've traveled overseas. So I think that's really important in convincing the employee and understanding what their needs are. So, and one question, someone came in, John posted, is learning more about targeting the U.S. Hispanic marketplace. So, John, I appreciate you sending me your email, and I'll reach out to you after the webcast, either today or tomorrow, about specifically the Hispanic marketplace. So, developing a successful strategy. So I already talked about multi-channel approach, going after the brokers, the agency employers. Some of the ways that you also can work with the Medical Tourism Association in this is we do a lot of educational webcasts, whether those webcasts are on medical tourism, whether they're participating in industry events like our medical tourism conference or regional events. And then we also have targeted social media strategies and campaigns. So with the targeted social media campaigns, as I was saying, is we have very large groups that we manage. We're the largest social media influencer in the U.S. insurance market, and the biggest, one of the biggest in the global insurance market. So I'll give you some examples. We run the Healthcare Reform LinkedIn group, which is the largest group for HR and insurance executives on healthcare reform. There's about, I think, 27,000 members. We run the Benefits and Health and Welfare Professionals group, which is HR executives, with about 26,000. We run the Corporate Wellness group with about 17,000. We run the Medical Tourism group with about 6,000. We have a Global Insurance group with a couple thousand, a self-funding group with a couple thousand. And we have literally thousands of people joining our groups every week. So we're doing some very sophisticated campaigns where it could be individual messaging campaigns, pushing out educational webcasts on medical tourism to specific hospitals or countries, and other activities, road shows and things like that. So I want to go into a couple things on the importance of social media. I'm a big believer in B2B social media, which is really LinkedIn, which is the key B2B method. And this is where we focus, and we literally have now over 300,000 B2B followers in over 40 different groups. And that our groups are doubling every 12 months. So while we have 300,000 this year, it's going to be 600,000 next year. And in 2016, it's going to be 1.2 million. So it's really amazing to see the growth. And, you know, the people you can contact in social media is amazing on LinkedIn. If you can connect with people that you didn't know existed, that can be your business partners. And so it's important to understand how to really use social media and LinkedIn and how to be very active. The Employer Healthcare and Benefits Congress, which is integrated within the MTA's Medical Tourism Conference, it's the largest employee benefits conference in the country for insurance and HR executives. So there was a survey that was just done literally last week, surveying HR executives working with employers on some key statistics within social media. So the first question was, which sources do you get your industry news from? 66% of respondents said social media. 86% said other internet, which is probably news websites, online news. 26% said television. 46% said trade magazines, industry magazines. So a majority of them are getting it through social media. And industry news through social media is really going to be coming through LinkedIn. So another question that was asked is, where do you feel you can receive the most timely and updated information on employee benefits? This is health insurance and other benefits within the employer. 40% said social media, 66% said other internet, 20% television, 20% trade magazines. This means that HR executives and insurance executives are using social media twice as much for getting updated information on what's going on in health insurance and employee benefits in the U.S. than the dedicated trade magazines that they get every month. So what this shows is social media is becoming the most influential source out there. So with agents, brokers, and consultants, we asked, which social media platforms do you use the most for business purposes? 91% said LinkedIn, 51% Twitter, 55% Facebook. So almost double the amount. So LinkedIn is the predominant use of what agents, brokers, and consultants who advise all the employers they're using for B2B purposes for social media. So this means you need to be in their channels, talking to them. And then the great part about it is we actually control and run those channels because we run the biggest social media groups for agents, brokers, and consultants in the U.S. insurance marketplace. So the other question specifically for agents, brokers, and consultants was, which sources do you get your industry news from? 80% said social media, 90% other internet, 18% television, 78% trade magazines. So once again, social media is one of the top ways they're getting information from. So the next question, specifically for agents, brokers, and consultants, where do you get your most updated information on your industry? 69% social media, 24% trade magazines, 4.1% television. That's huge. That means you're getting your most updated information on social media. So if there's a new trend or benefit such as medical tourism, I would say you're getting it on social media. One question that came in from Hector, who's a small ambulatory clinic, and saying which business is successful in medical tourism. So it depends upon the surgeries you're providing and the cost to determine, do you go after, does it make sense where self-funded employers will save enough to incentivize employees to come to your facility, focusing specifically on, Hispanic Americans or regular Americans. We would really have to look at the savings and then see if it would fit within fully insured plans, and then where you're located. For example, Hector, if you're in Mexico, I know there's UCLA did a study of 1 million Mexican Americans travel back to Mexico for care each year for care, so that could be a big focus. So you're in Mexico City. So definitely Hispanic and Mexican Americans. And then the other area would be cash-paying patients. But I'll reach out to you after the call, after the webcast, so we can talk, and we can really delve into that a little bit faster. So that's going to conclude a lot of the core part of our webcast. And if you have questions, you can feel free to email us or call us. We can walk you through anything. One of our last slides, like why you should partner with the MTA, access to patients. I think we have in here, we just did what we call a game changer. And we changed our membership benefits where now you can get guaranteed patient leads. So the MTA, we get thousands of patient leads, healthcare consumer leads that come into medicaltourism.com, the #1 portal for medical tourism for patients, and through the MTA website every year. And now, depending on the level and joining, you can get up to 500 patient leads. And then one of the things that we opened up for the industry is we work with all the buyers of healthcare all around the world. I mean, we work with buyers of healthcare in every region: the Middle East, Asia, the U.S., Europe, Latin America, and they participate in our webcast, they participate in our conference, they're in all our social media channels, they read our surveys, they read our magazine. And so what we realized is that in helping the industry grow, we want to help our members grow. So for the first time, we're also going to start providing guaranteed buyer leads. Where you can get up to 200 buyer leads per year of buyers who may say send patients, employees, insureds to your facility, whether you're a certain level facilitator or a hospital or clinic or government. And then the other thing that we have just rolled out is in sponsorship is guaranteed networking meetings at the conference for sponsors. So this is something totally new that we've done. There's always been networking meetings. But now there can be up to 50 guaranteed one-on-one networking meetings, with buyers that would want to send you patients, and that's for whether you get booths or you could go with a food and beverage sponsorship that doesn't have a booth and get your networking meetings. And we've done that because we've really tried to focus on listening to what everybody wants. And the feedback from everyone in their industry is they would like more patient leads, they'd like more buyer leads, and at our conference, people want to have very focused one-on-one meetings and want to be guaranteed that they get those meetings. So we're rolling out those guaranteed meetings for sponsors. So if anyone has any questions on those, please let us know. And on the guaranteed meetings at our conference, we bring in, last year was about 2,200 attendees. We're shooting for about 2,500 to 3,000 this year. We bring in, if you're on this webcast, it's because you're interested in the U.S. insurance marketplace. Integrated within the Medical Tourism Conference, it's the largest U.S. insurance conference for HR and insurance executives. There is none that's bigger. So every leader in the insurance market is going to come. All the big employers, all the insurance companies, they're all there. They're attending. They're sponsoring. This is a picture of our conference last year, the packed exhibit hall. It's not like anything else in the industry. It's not like these other events that are going on where they say they're having 2,000 attendees or 500 attendees, and then you come and there's 50 people or there's 100 or 200 people. I know that's one of the biggest challenges in global events is that there's no quality medical tourism conference out there really globally except our global event. But we're also rolling out regional events this year because of that. And one of the things that we focus on all year long is quality buyers and qualified buyers. We're the only industry event that brings in quality buyers. So we're not going to bring in people who are consultants, who are sellers, who are trying to sell you services. We're not going to bring in facilitators who are stealing money from patients or being criminally investigated or who don't send patients. And I say that, and I say it really passionately because we do see other events doing this. And then once we started using the word qualified buyers, then they started using the word qualified buyers. But if you look at our attendee list, we're really transparent. If you haven't been to our events, you should really, not only check it out, but call us, because I think it's important is engaging with us to figure out how you can get the most out of your conference experience in planning of identifying who you want to meet through the networking software, talking to our staff where maybe we could help connect you, what sessions you want to go into. We're going to have over 200 speakers this year. So I think it's having a very, very defined experience. And if you are looking for partnering with multinational employers and insurers in your countries or your regions to get expats or regional business, we bring in all those buyers too. So we have like the Global Medical Network Director Summit that brings in all the global insurers that contract with hospitals all around the world. Those people are at our show. We have the Global Ministerial Summit, bringing in the ministers of health who spend billions of dollars a year sending patients overseas. We have a lot of summits behind the scenes. If you're a facilitator, you definitely want to come and participate in our facilitator forum and sit around the table with leading facilitators and collaborating and working together. So we have a lot of these buyer meetings going on within the conference that bring in all the buyers. And I think it's really important to really target these markets. So it's not just going after U.S. buyers. It's not just going after ministers of health from other countries. We have the Global Benefits Association that holds its annual meeting at our conference that brings in all the big multinational employers. So it's going after multinational employers that have operations in your country to say, hey, send us your expats that are living here, rather than going to other hospitals or being sent to a country outside. You go send to a hospital outside our country. And if you're a hospital, get out of the mindset. We already have contracts with the international hospitals, because if you're not getting any kind of volume from those hospitals, it's why, and it's because just because you have a contract, that can be a contract with one division, and you don't have a contract with the right division. Or the people who are referring patients within the insurance company have no idea that you have a contract and don't even know who you are, because those international insurance companies could have contracts with thousands or tens of thousands of hospitals around the world, so you're not even on their radar. It's really understanding, and I think that the biggest part about our event, which is important, or even coming to our regional event, is building the business relationship one-on-one with the buyers of healthcare. That's what's going to get you business. I see so much business that people don't get it because they're not meeting the buyers. Or I've seen countries that they were at the top of medical tourism, and then a couple of years later they've dropped off, and they're losing patients because they're not meeting their customers. And now another hospital is meeting their customers. So you could be getting, I saw there was one hospital in Latin America that they met one facilitator at their conference. They got 500 patients that year, like $5 million in business, so like $10,000 a procedure. And they actually decided to stop marketing. So they cut their budget in marketing, in magazines, and advertising. They cut their travel budget, and they stopped exhibiting at conferences, including our show. What happened to their medical tourism business? It totally tanked. And the reason why it totally tanked is they thought they had made it, and they said, we now are getting $5 million just from one facilitator. We don't need to do anything anymore. All the business is going to start coming to us. So what happens now is the people that they were getting business from are now going to other international events like ours, and they're meeting other hospitals. And then new players who are coming in the industry, new insurance companies, new employers, they don't even know that hospital exists, because when they're going to an event, they're meeting all their competitors. So what the hospital doesn't realize is you've lost your customer base. You've lost all your clients. And you have to constantly be in everyone's face, specifically for that business. So with that, that's kind of, end our webcast today. If anybody has any questions, please feel free to, email us. We'll also respond to everyone's questions individually, and then we'll make the webcast available in the next 48 hours to everyone. So appreciate everyone coming on the webcast, and I hope everyone has a great week. Take care.